Hi everybody, welcome to our module on cystic fibrosis. Cystic fibrosis gets its name from fibrous cysts that were seen in the pancreas when people first began studying the disease in the 1930s. It's an inherited genetic disease that gets passed along in an autosomal recessive pattern, so both parents have to be carriers. And children with cystic fibrosis get thick, sticky mucus in their lungs and GI tract, and this is the cause of all the pathologies. And you should know that it's a very common cause of chronic lung disease in children. Chronic lung disease in children is rare. It's much more common in adults who are smokers, but children who have chronic lung conditions often have cystic fibrosis. The protein that is abnormal in cystic fibrosis is called the cystic fibrosis transmembrane regulator, or the CFTR. So the CFTR protein is what's abnormal in the disease, and the CFTR gene encodes for that abnormal protein. So let's talk about what the CFTR protein does. The CFTR protein is an ATP ion transporter, and what this means is that it allows ions to pass through a channel and that it uses ATP. It has different functions in different places of the body. In particular, it has important functions that relate clinically to cystic fibrosis in epithelial cells and in sweat glands. In epithelial cells, because it is an ion channel, it allows chloride out of epithelial cells. It uses ATP to do this, and when the chloride leaves the epithelial cells, this draws water and sodium out, and this hydrates mucosal surfaces like those found in the lungs and the GI tract. So what this means is patients with cystic fibrosis who have an abnormal CFTR protein will have dry, sticky mucosal surfaces because the protein is not working. In the sweat glands, the CFTR protein removes sodium chloride from sweat. It makes sweat hypotonic. What this means is that cystic fibrosis patients have a high sodium chloride content in sweat, and we'll talk later about how you can use this diagnostically to determine if someone has cystic fibrosis. So that's the protein, but now let's talk about the gene mutations. There are many mutations that have been identified to cause cystic fibrosis, but the most common, and the one you should definitely know for your boards, is the delta F508 mutation. It's a deletion of 3 DNA bases that code for the 508th amino acid phenylalanine. The most common consequence of having a mutation in the CFTR gene is abnormal processing. The protein doesn't fold properly, and it prevents protein trafficking to the correct cellular location. So don't get fooled on an exam and think that patients with cystic fibrosis have an absent protein. They don't. The protein is there. It's just abnormal, and it can't be folded and trafficked to the correct position in the cell. So to remember all the pathophysiology and symptoms of cystic fibrosis, just remember that there's going to be thick mucus. When you have thick mucus in the lungs, the patients are going to develop recurrent pulmonary infections. It is very high yield to remember Pseudomonas, which causes most of the pulmonary infections in CF patients, also sometimes Staph aureus. These children are going to subsequently develop chronic bronchitis, and they can also get bronchiectasis. In the GI tract, the thick mucus is going to impair the flow of bile and pancreatic secretions. This is going to result in malabsorption, especially of fats, because recall that you need pancreatic enzymes to absorb fats. The result is that you're going to lose fat-soluble vitamins like A, D, E, and K. You're going to become deficient in these vitamins because you can't absorb them. And you're also going to get steatorrhea, which is fat in the stool. This disease is usually diagnosed in very young children, usually under 2 years of age. So these children aren't going to be able to verbalize their complaints. So they're going to be identified through a couple of different ways. The most common way is that they develop recurrent respiratory infections, and this leads to testing that diagnose cystic fibrosis. About a quarter will just have failure to thrive, and then about 20% will have a bowel obstruction called meconium ileus. We'll talk more about that in a minute. So what are the symptoms of cystic fibrosis lung disease? Well, the first is a productive cough. All that sticky mucus is going to create a lot of coughing. The lungs can become hyperinflated on chest X-ray, and there can be an obstructive pattern on pulmonary function tests. Later, as the disease progresses, these children can get chronic bronchitis and bronchiectasis. And you should know that they're often stable for a while and then develop an acute exacerbation. And Pseudomonas is a major cause of both chronic infection and acute exacerbations. And when you do pediatrics rotations in the hospital, you'll often see CF children who have been admitted for an acute exacerbation of their disease. They need antibiotics and oxygen until they get over the acute illness. All that sticky mucus is going to clog up the pancreatic ducts, and this is going to lead to a couple of pancreas problems. The first is chronic pancreatitis. This can happen to children with CF. If the pancreatitis goes on for long enough, these children can burn out their islet cells, and they'll develop CF-related diabetes. Because those pancreatic enzymes can't get to the gut, these children will have fat malabsorption. And one of the main symptoms of fat malabsorption is steatorrhea. And people who have steatorrhea have frequent stools, they're foul-smelling, They're oily or greasy, and the stools may float. Nobody likes to talk about this, but most of our stools sink to the bottom of the bowl. Stools that float are very abnormal, and this is something that a parent may notice from a child. Another clinical consequence of pancreatic insufficiency is a deficiency syndrome of one of the fat-soluble vitamins A, D, E, or K. I talk about these vitamins in detail in the biochemistry modules, but for our purposes here, I'll just remind you of some of the key symptoms if you become deficient in one of these vitamins. If you're deficient in vitamin K, that's like being on warfarin therapy. You will have a coagulopathy. If you're deficient in vitamin D, you can get rickets if you're a child, or osteomalacia if you're an adult. Deficiency of vitamin A usually presents as night blindness. That's one of the first signs. You need vitamin A in order to be able to see properly. And vitamin E deficiency presents as ataxia and nerve problems, and also hemolysis. So recall that I said one of the ways that CF often presents in infants is with a bowel obstruction from meconium ileus. So let's talk about what that is right now. So meconium is the first stool of the newborn. It's usually very thick and sticky, and it usually passes shortly after birth. Meconium ileus is a bowel obstruction from that meconium, and it occurs when the meconium is too thick and sticky and a plug forms and obstructs the bowels. This results in abdominal distension and vomiting, and it results in air fluid levels if you take an X-ray, and the child will fail to pass meconium, meaning they won't have a bowel movement in their first few days of life. And if you look over here at the right, this is an X-ray from an adult with a bowel obstruction, and I just want to show you the air fluid levels. So when your bowels are obstructed, fluid backs up behind that obstruction. In addition, you don't realize this, but you're constantly swallowing air. So air and fluid get mixed up in your bowels, and you get levels called air fluid levels. So you look right here. This is a little bit of fluid here, and there's air above it, and you can see that the loops of bowel are dilated. So these sort of flat areas of fluid are what's called an air fluid level, and they're seen in bowel obstruction. And just remember that meconium ileus is a classic presentation for cystic fibrosis. Let's talk about some other symptoms that children with cystic fibrosis can develop. They can get biliary disease, so that sticky mucus can obstruct the bile ducts. And so children who don't have bile in their stools will have pale or clay-colored stool. Bile is what makes our stools brown. This will cause obstruction and lead to elevation of the LFTs. They can get hepatomegaly, and if it goes on long enough, they can get cirrhosis and sometimes develop gallstones. About 95% of males with cystic fibrosis are infertile, and it's important, especially for step 1, that you know the mechanism of this. This is because they have an absence vas deferens. So we don't know exactly why this happens, but we believe the CFTR protein is important in development in the fetus of the vas deferens. So it fails to develop, and recall that the vas deferens is what carries sperm from the testes to the penis. So these children have a problem with sperm transport, not spermatogenesis. And when they get older, they can have children with assisted techniques because the sperm are being developed. Some other clinical findings in cystic fibrosis children are digital clubbing, and this is a picture of digital clubbing over here on the right. So normally your fingernails should have a gentle downward slope, sort of like this, but in cystic fibrosis patients, they can become rounded, and that's called clubbing. You also see that in children with congenital heart disease who are cyanotic and some other pulmonary conditions. And then children with cystic fibrosis can develop nasal polyps. The mechanism is not clear, but it appears that that thickened mucus can develop into polyps inside the nose, and these can become obstructing and lead to sinusitis and nasal congestion. So let's suppose you have a child with recurrent respiratory infections, or maybe a newborn that has meconium ileus, and you suspect cystic fibrosis. How are you going to make the diagnosis? Well, the best first test is the sweat chloride test, and this uses a kind of strange technique called pilocarpine iontophoresis. And iontophoresis means using an electrical field for a test. And recall that pilocarpine is a muscarinic agonist. It's a parasympathetic agonist that's going to induce sweating in the child. So what you do is you put some pilocarpine on a gauze and you place it on the skin, and then an electrode is placed over the gauze, and a small electrical current drives pilocarpine into the skin, and this creates sweating. And the reason you have to go to all this trouble is because you need a lot of sweat for this test. You can't just put the child in a hot room. You have to actually generate a significant quantity of sweat to analyze. The sweat's then collected on filter paper, and the chloride content is analyzed. And a high chloride content suggests CF, because remember that CFTR protein removes chloride from sweat. So these children are going to have a high amount of chloride in their sweat. If this test is abnormal, you follow it up with DNA testing, but this is done as a screening test because the DNA testing is expensive and it takes time to do. Now, there are rare CF patients who have a negative sweat test but still have cystic fibrosis. These kids usually have milder disease. They mostly have recurrent pulmonary and sinus infections. So if symptoms are highly suggestive of CF, but the sweat test is negative, you can do another test called the nasal transepithelial potential voltage. This is where you essentially measure the voltage across the nasal epithelium, and cystic fibrosis kids have a more negative voltage, and this is because they have abnormal sodium processing from that CFTR gene. This is uncommonly done, but there are situations where the sweat test is negative and you don't entirely believe it. So how do you treat cystic fibrosis? Well, one of the first things you want to do for these children is promote the clearance of airway secretions. One way to do this is using an inhaled drug called Dornase alpha. This is an enzyme that lyses DNA. It turns out that there is a lot of highly polymerized DNA in those thick mucus secretions, and this is because dying neutrophils spill their DNA and then it gets polymerized with other DNA. So this inhaled drug can help break that up. We also just sometimes used inhaled saline because the saline can help moisten those secretions and clear them. And then there's an older drug called N-acetylcysteine that really isn't used much anymore. This cleaves disulfide bonds in mucus glycoproteins. Problem is it induces bronchospasm in some kids, and it's been shown to inhibit ciliary function. So people have largely stopped using acetylcysteine much anymore. Another option for treatment is a drug called ivacaftor. These are tablets, and these increase ion flux. This is a drug that's only useful in CF kids with a very specific mutation called G551D. There are exacerbations, as I said before, and these are usually treated with antibiotics. And then finally, lung transplant is commonly indicated for children with CF. So to be eligible for a lung transplant, you have to be relatively healthy. There are a lot of elderly patients who have sick lungs, but they're not well enough to survive the operation and to tolerate all the immunosuppressant drugs. Kids are generally good candidates for lung transplantation because once you get the new organ in them, their overall body is relatively healthy. So you will see a number of CF kids on lung transplant lists. Other treatments are to replace pancreatic enzymes and supplement the fat-soluble vitamins. And then, of course, children with CF need vaccinations. You don't want them to get the flu or pneumonia. The average lifespan in a patient with cystic fibrosis is shortened. It's reported to be about 37 years, although many pulmonologists will tell you that they have patients with cystic fibrosis who are living much longer than this, and death occurs early, usually because of lung complications. And then finally, it's not always done, but you can perform screening for cystic fibrosis. This is done prenatally in some parts of the United States. Parents are tested for 23 of the most common cystic fibrosis gene mutations in the U.S. Often the mother is tested first, and you stop the testing if she's negative. However, if she carries one of these gene mutations, then you go ahead and test the father as well. You can also screen in the newborn period. Many babies with cystic fibrosis have increased blood levels of a substance called immunoreactive trypsinogen, or IRT. You may know that trypsinogen is a zymogen. It's a precursor of a pancreatic enzyme synthesized in the pancreas, and levels of immunoreactive trypsinogen are increased in many babies with cystic fibrosis. So you can do a simple blood test, often with a sample of blood from a heel stick on a newborn baby. If the level of IRT is elevated, then you go on and do a sweat test and further confirmatory testing. And that concludes our module on cystic fibrosis.